Hello, everybody. It's Dr. Rose Lovell back again to do another in our series between Natividad and Epicenter of our little monthly lecture sessions and Q&As and just kind of social get-together. And this month we'll be doing a little 30-minute session on how to access transition-related care for our transgender adults and youth and gender non-conforming adults and youth. As I mentioned, this is our monthly session. I'm going to encourage everybody to go into the comments, leave questions, because we'll have a question and answer session at the end. And if I'm randomly distracted at any point, it's because I have a cat right next to me. So welcome, everybody. As I mentioned, I'm Dr. Rose Lovell. I'm one of the resident physicians who's at Natividad, and I'm going to hand it over to the wonderful Epicenter crew to go ahead and introduce themselves and talk more about the services that Epicenter offers for our LGBTQ, et cetera, youth here in Monterey County.
Hi, everyone. My name is Sam Gomez. My pronouns are they, them, theirs, and I'm the Deputy Director of the Epicenter. So our Gente is our LGBTQ plus program of the Epicenter, and we offer various support services for our LGBTQ plus youth. We offer social support groups every week via Zoom, and those are Wednesday nights at 7 p.m., where it's a space where LGBTQ plus youth and their allies can have dialogues on how their week is, vent about anything, really just holding space for each other and supporting each other during this time. We also have community events. Obviously, those are, canceled for in person, but we are working on ways to provide those virtually. We also have community trainings as well. So let us know if any organization, or if you have folks in the community who would just like to learn about the LGBTQ plus community, the differences between gender and sexuality, and other topics pertaining to the LGBTQ plus community, and specifically around youth, then let us know. You can reach us at our Gente at epicentermonterey.org for more information. And thank you so much. Follow us on our social media. We'll be going over all the various social medias that we have at the end. But thank you again, Dr. Rose, and I'll pass it back to you.
Thank you so much, Sam. So I want to start off by acknowledging that this week is what's commonly sometimes called the sort of Trans Week of Recognition or Visibility, because it contains the Trans Day of Remembrance. That's this Friday in commemoration of all of the trans people who have been murdered over the years. It's a somber note to start on, but up in Watsonville Plaza, there will be a vigil this Friday from 5 to 7 p.m. I would be there, but I'm in clinic at that exact moment. So I hope all of you will have a chance to at least think of the people who have been lost, talk about the people who have been lost, even if you can't be at the vigil yourself. I just want to bring up a couple of statistics. This is from the wonderful folks over at transrespect.org. They have infographics formatted for Instagram. They have them in English, Spanish, and many other languages. The numbers of trans folk who are being murdered every year is going up. It's been 350 this year to date, most of whom are trans women of color, and that's throughout the entire world. And just to kind of shout out our half of the globe, a lot of the folks who we've lost this year were in Brazil. The United States and Mexico are kind of in the same category, with 20 some odd lost in the US this year, and Mexico 40 some odd. So shout out to the folks who are putting all these data together. We will continue to be working really hard to make certain that they are not forgotten and that we don't lose anybody else. So Trans Day of Remembrance, the vigil is going to be starting at 5 p.m. Bring a mask. It will be socially distanced at Watsonville Plaza in Santa Cruz County. Shifting from that very somber note, this evening tonight really starts off a series of talks. Part of what we heard last time is, people want to hear more about transgender-related healthcare. So we're kind of going to do a series tonight. We're going to start on how do you access transgender-related healthcare. Specifically, hormone therapy is most of it. We're going to talk about WPATH and the standards of care. We're going to talk about some basics to think about before you start hormones. Next month, probably December 19th, but we'll let you know. December 12th. We're going to focus in on masculinizing hormones. January is going to be feminizing hormones. And then again, February, masculinizing surgeries, and March, feminizing surgeries. This is all tentative. And for those who are interested in specific topics, but who are non-binary, then choose the one that most closely fits the transition that you need. I will be non-binary inclusive in these. So the same disclaimers as last month. I have no financial ties. The views that I express are my own. They're not related to my hospital, my residency program, or my outpatient clinic. I acknowledge that the terminology and word preferences vary depending on the person. So if I use a term that is not exactly the term that you most prefer, my apologies. And just note that the information that I provide is intended to be informational only. It doesn't constitute medical advice like it would be in an actual doctor's appointment with me. So let's start by talking about what different kinds of doctors can actually provide medical care, because I feel like this gets very confusing very easily for folks. Your medical home, where things should always start, is what's called primary care. And a primary care physician, a PCP, is a person who's trained in family medicine, internal medicine, or pediatrics. And which one it is for you depends on your age, your gender or sex, and sometimes, and then whether or not you are pregnant. So family medicine can take care of all ages, doesn't matter who you are, whether you're pregnant or not, we can take care of everybody. Internal medicine is typically adults only. So 18 plus is the general rule of thumb, although I've known some that will treat 16, and they're not trained in pregnancy-related care in their medical training. Pediatrics is typically for less than 18, although again, I've seen some pediatricians maintain their patients until 26, actually, in some cases, depends on the pediatrician. And at that point, they will transfer the care to either a family doctor or an internal medicine doctor. Ideally, your PCP should be able to provide the vast majority of your medical care, including hormone therapy. You do not necessarily need to see a specialist to get hormone therapy. But some specialists who may be involved in your medical care are an obstetrician gynecologist or an OBGYN. They are specifically trained in the care of people who have or genetically should have had a uterus and ovaries. Some OBGYNs will also treat trans women. It really depends on the OBGYN. They are at heart surgeons, and they'll tell you this too. Some people will treat an OBGYN like their primary care, but they're really trained first and foremost as surgeons. They are specially trained in the care of folks who are pregnant. And like I said, they also do surgeries based on the uterus, the ovaries, and the vagina. So that's basic field. Then there's endocrinology. That's someone who's internal medicine trained. So they're trained to treat adults, non-pregnant adults, and then they do a couple of extra years of training specifically focused on hormones. So they focus on things like diabetes, thyroid conditions, growth hormone conditions, and sex hormones. So when people think of a specialist providing transgender care, it's usually an endocrinologist they think of. There's the pediatric endocrinologist as well, who's a specialist in the endocrine state, so hormone states of people who are under the age of 18, classically children. And again, pediatricians not typically trained in pregnancy-related care. And then there are surgeons of many, many different types with many different types of training. Since I am not a surgeon, I am more of a physician. I'm more a medical physician. I won't pretend to have any particular special knowledge about how the exact differences between the surgical specialties, but many, many different kinds of surgeons. You may also see what's called a mid-level provider. So these are people who have not done medical school. They are not physicians, but they sort of occupy this space between a nurse, a registered nurse, and a physician. So a nurse practitioner is a nurse who's completed nursing school, who then gets 1 to 2 extra years of didactics and clinical experience, which unfortunately is mostly shadowing. Their scope of practice depends on their training. In the state of California, now they are allowed to practice independently. And then there are physician assistants who could have been EMTs, paramedics, they could have been nurses, but they go back and they get at least 2 additional years of training, which closely mimics medical school in its style, and they practice under the license and under the direct supervision of a physician. They commonly participate in medical care now, and we sort of call them physician extenders. So you may or may not end up seeing an NP or a PA in the course of your medical care, but do recognize that as useful as their experience is, they are not physicians. So to get into how you get access to medical care, I'm going to start by talking about WPATH and the standards of care, because that determines everything else. So WPATH, as I mentioned last time, is the World Professional Association for Transgender Health, formerly known as the Harry Benjamin International Gender Dysphoria Association, which is way too many words, in honor of Dr. Harry Benjamin, who was an early pioneer in the field of trans health. It's a nonprofit, interdisciplinary, professional, and educational organization, which is devoted and dedicated to transgender health. It includes many people who are trans, many people who are cis in its ranks. And for many years, actually, our president was a trans person. Includes student members, physicians, surgeons, psychologists, lawyers, and on and on and on. You're welcome to come to our website at WPATH.org for more information. And part of what WPATH does is it produces the Standards of Care, which has way too long a title, the Standards of Care for the Health of Transsexual, Transgender, and Gender Nonconforming People. This document sets professional standards for the ethical medical treatment of transgender and gender nonconforming people. All physicians and surgeons and therapists are supposed to follow its guidelines, at least in the spirit of the guidelines. It is freely available. You can go to the WPATH website and download it. It's in English, it's in Spanish, it's in many other languages as well. So how do you get hormones? First, I cannot recommend highly enough having a physician involved in your hormonal treatment. It can be your primary care doctor, can be a specialist. I do know that some folks are in a spot where they have no other option than to get hormones themselves. I can't recommend doing that, medical legally, among other things. I do strongly recommend having a physician involved. What do the standards of care specifically say about requirements for hormones, though? So, because they do say, they lay out requirements. So this is Standards of Care version 7, and it is different from earlier versions. What do they say? This is very technical, but let's get into it. They say that a psychosocial assessment must be performed by a qualified health professional. If that health professional cannot do a psychosocial assessment, then they need to get a referral letter from a mental health professional. What does that mean? It means the doctor, because really that's what we're talking about, or an NP or a PA or whomever else, but a doctor needs to sit there and talk to you and ask you questions about your psychological state and your social support, and make certain that you're not actively hallucinating, for example, and that you meet all of these other criteria. So they have to meet these 4 criteria in order to get hormones according to the Standards of Care, and they're fairly reasonable, actually. One is you need to have gender dysphoria, and I'll get into the specific definition of that. They say persistent and well documented. Persistent meaning it's been there for longer than like a smidge of time. If you wake up one morning and suddenly have gender dysphoria only on that day and you've never had it before, it's really hard to justify treatment. And maybe there's something else going on. The well-documented part, I think, is where people get a little tripped up. I don't emphasize it in my own personal practice. For me, it's enough that somebody says, yeah, I felt this for a long time, and I go, great. But this is what the standards of care says. Then the person who we're treating has to have capacity to make a fully informed decision and to consent for treatment. So you have to understand the risks, and you have to understand the benefits, and you have to be able to then make that decision and consent, which is a medical legal term, but to say, yes, I understand the risks of hormones, I accept that risk, and I still wish to go forward with hormones. They do say that you have to be the age of majority in a given country. That means an adult in whatever country it is. So in California, it's age 18 or it's age 16 if you're emancipated. And I'll get into there's details there. We can't actually treat adolescents. It's just details. And then if there are significant medical or mental health concerns, which are there, so diabetes, high blood pressure, history of a heart attack, depression, anxiety, PTSD, on and on and on, they have to be reasonably well controlled. My medical interpretation of this is basically, if you're actively hallucinating, I need to get that under control first before we can really start working on your dysphoria. Or if you're at risk of having a stroke right this moment, probably not the best time to start estrogen. So let's get that under control so that you can be healthy to then have your hormone therapy. So what is that gender dysphoria thing that they're talking about? Aside from what I mentioned with the talk we did last month, and go ahead, we'll have links somewhere for you to click. It is a diagnosis. It is a medical diagnosis and a mental health diagnosis, both. I sort of say associated with being transgender. There's a specific diagnostic criteria, which I have on the screen for you. Basically, a physician or a psychologist can diagnose it, and you have to have two of the following, and I'll just read them for those who don't have access to a screen or have visual impairment. But really, it's very fancy medical language, and I'll translate it. So, a marked incongruence between one's experienced or expressed gender and primary and/or secondary sex characteristics. Meaning, you have there's a difference between your gender identity and your sex or your sex assigned at birth, just like I talked about last month. Point number 2, there has to be a strong desire to get rid of one's primary or secondary sex characteristics because of that marked incongruence. So, in other words, these first 2 bullet points, 1, there has to be that disconnect between gender and sex, and 2, and mind, out of all 6 of these points, you only need 2 of them. There can be a strong desire to get rid of breasts or penis or facial hair or whatever. Point number 3, there can be a strong desire for the sex characteristics of the other gender. So not just get rid of breasts, but then have a penis. 4, a strong desire to be of the other gender. So to be a woman or to be a man. And this is very, they do have language this is from the Diagnostic and Statistical Manual. There is a little bit of language honoring non-binary people, but it's still a very binary system, really. Point number 5, a strong desire to be treated as the other gender. So I want other people to treat me as a woman. And 6, a strong conviction that one has the typical feelings and reactions of the other gender. So I feel like a woman, and I feel like I'm reacting to things like a woman, like I cry all the time. Totally stereotyped, but you really only need 2. Do I go back to this list every time? No, because I'm not going to memorize all this. But this is the psychological, this is the Diagnostic and Statistical Manual definition. So it can be that you have that gender-sex mismatch, and you want to transition, and that's enough. The diagnosis also requires that you have what they call clinically significant distress or impairment in social, occupational, or other important areas of functioning, meaning you're upset by this, or it's causing you difficulties in your social life, at job, and your work, or your home life, or somewhere else. Which again, most of the people who come to see me, at least, are distressed because they need treatment, and I go, "Yep, let's get you hormones." It does not require that you be feminine or masculine in a particular way. It does not require you to want surgery. There's lots of other things that it does not require. But it does require that there be distress, that this gender-sex mismatch, that all of this other stuff, I just went back a slide to the diagnostic criteria, that caused distress or difficulty functioning. That's a common requirement of all psychological diagnoses. And this is totally like in the medical psychological realm. So if that feels a little bit over your head, that's okay. It's not a permanent diagnosis, unlike the old gender identity disorder, if you were familiar with that. And then the process of transition is considered treatment for gender dysphoria. It's the only treatment that we have that works. So I had mentioned in the standards of care that you had to be 18, basically. What if you're under 18? So, unfortunately, you do need the consent of your parents or guardians or caretakers or whoever legally makes your medical decisions. I will note that in the state of California, minors are allowed to make their own medical decisions regarding certain things. So parenting, birth control, abortion, and mental health care. So you can get an abortion, for example, in the state of California without your parents being notified. How you pay for that gets complicated. But if I give you birth control, I don't have to tell your parents because you get to make that decision. Unfortunately, gender affirming care does not fall under that. The standards of care do not specify requirements for minors to get hormone therapy. So for minors to get estrogen or testosterone, they really only talk about criteria for puberty blockers. And I have here on the screen a fun picture of one of the implant version of puberty blockers. And we'll talk about puberty blockers more in a future lecture. But basically the requirements for receiving puberty blockers is very much, is very much similar to the other requirement for adults. So the adolescent must have a long-lasting or an intense pattern of gender nonconformity or gender dysphoria, whether suppressed or expressed. So you can have had the feeling for a long time and not told anyone and not acted on it, and it still counts. You don't have to be out. 2, the gender dysphoria emerged or got worse with puberty, which is a super common pattern. 3, any coexisting psychological, medical, or social problems that could interfere with treatment have been addressed. So you don't have super bad diabetes, or you don't have a family that is tearing apart at the seams that would make it difficult for you to have regular access to hormones or psychological care. 4, the adolescent has given informed consent. And when the adolescent has not reached the age of consent, so technically you can't consent if you're under 18. If you are under 18, then your parents, caretakers, or guardians have consented and are involved in supporting the adolescent. That's the language that they use. So you have to have gender dysphoria. It either emerged or got worse with puberty, because they only really talk about to get puberty blockers, like it has to have gotten worse because of puberty in order to get it. We've dealt with anything else to help make it safer for you, and parents, guardians have to consent. If you're familiar with some of the chatter online, you may notice that nowhere in here have I said that therapy is required for people over 18 or people under 18. Not required for hormones. Used to be. I do recommend it, particularly for those of you who are under 18, to support you through the process and help you and support your family. So super complicated medicalese. Let's say this again in plain English, because I'm certain I've lost some people because I hate staring at that stuff. In other words, You either need to be 18, 16 and emancipated, or have parental or guardian support. You need to not have be actively psychotic or delusional or demented. You need to have experienced dysphoria for a significant period of time, and you have to be able to tell your doctor about it. And you don't need to see psychology. There is a slightly different model, which is the informed consent model, which you may hear about. I see still people sharing lists online of like, these are informed consent clinics. So what do they mean by that? Old versions of the standards of care required psychotherapy to get hormones. They required months of therapy or years of therapy. They required that you present as your gender for 12 months before you got hormones, which is, seems dangerous to me. And they had other restrictions at different times. So the informed consent model really kind of emerged in that setting. And what an informed consent model means is, if you can tell me that you understand the risks and benefits of hormone therapy and that you consent to the treatment, and I think that you have the capacity to consent, you're not actively psychotic, you're not demented, that it seems to me that you understand, then you can get hormone therapy. Boom, done. But Standards of Care 7, if you kind of sit back and think about what they're saying, makes it less necessary, because really that's what they're saying. And as a side note, the Standards of Care 8 are in development, and there's a lot of movement within WPATH from the chatter that I'm hearing, to try to make it so that there's less gatekeeping. Before you start hormones, a couple of things to think about. One is think about fertility and think about whether or not you want to have biological children, because therapy cannot be guaranteed once you go on hormones. It can with puberty blockers, but not estrogen, testosterone, spironolactone, etc. So really talk with your doctor about it. Having biological, like I said, you may want to bank your eggs or your sperm. Think about it. It's okay if you don't want them, but I need you to think about it. 2, if you can, do what you can to improve your health. And I acknowledge that that can be really hard when you're struggling with gender dysphoria. So do the best you can. Quit smoking if you can, cut back on your drinking, eat well, exercise, lose a few pounds, control your chronic medical conditions if you can, etc. Talk with your doctor about that. Really, there are very few to no medical conditions that really mean I can't do hormones for you. It's just that some things make it riskier than others. Number 3, discuss and consider the medical risks of hormones with your physician. Hormone therapy is not risk-free. It's pretty low risk in terms of the grand scheme of the medications that I prescribe, but it's not risk-free. And so think about it, read about it if you can, talk with your doctor about it. And then 4 is read about the limits of hormone therapy. There's a lot of beautiful things that hormones do. There are also things that they can't do. For example, not going to fix your height. If you're 6 feet tall and you're going on feminizing hormones, there is nothing I can do about the fact that you're 6 feet tall. The hormones aren't going to fix that. So helpful to talk with people who have been there and get a sense of what the hormones can and can't do for you. Fairly quickly, but what about surgery? Top surgeries, both masculinizing and feminizing. All those same requirements as hormone therapy. But, and this is why I generally also recommend that you talk to a therapist, you need a letter and support from a mental health provider. I can't write that for you. That has to be a therapist or social worker who has talked with you and had a session with you. Doesn't have to be in regular therapy. For feminizing top surgery for breast augmentation, they really do recommend, they say in the Standards of Care 12 months, I really recommend more like 3 to 5 years of estrogen therapy or feminizing therapy before getting breast augmentation, because you get a better result. Again, not required. For hysterectomy, so removal of the uterus, removal of the ovaries, and removal of the testes, so gonadectomy is what that's called en masse. Same criteria as hormone therapy, plus 12 continuous months of hormone therapy unless there's a medical reason not to. and one letter each from 2 different mental health professionals. So again, reason to talk to a therapist. And this is all standards of care. I have no control over this. And then genital surgery, so vaginoplasty, metoidioplasty, phalloplasty. Same criteria as hormone therapy, plus those 12 continuous months of hormone therapy, unless there's a medical reason not to, and 12 months of living, they say, this is their language, living in a gender role that is congruent with gender identity. So, meaning, if you identify as a feminine person, dressing and acting femininely with female pronouns with a feminine name. Reverse for those who are masculinizing. Used to be called the real life experience. And one letter each from 2 different mental health professionals and 1 letter from your hormone provider, who may be me, but a doctor like me. And most surgeons will follow these guidelines. And the surgeons actually, what I've been seeing is they'll give you stuff, they'll give you a letter and you take that to whoever needs to write you the letter, and they will tell us what they need to hear in the letter. How can you afford all of this? Oh my goodness, it's so expensive. It is. But per California law, a California insurance policy must cover transgender-related healthcare. So that's all commercial insurances in the state, Medi-Cal, which is the California version of Medicaid for those who may be seeing this from out of state, and managed Medi-Cal like Central Coast Alliance for Health, which is the Medi-Cal for Monterey County and Santa Cruz County. Does not include military insurance, does not include Medicare. So if you're Medicare only, transgender-related medical care may not be covered. Other tips that I have in terms of the cost, some forms of hormones are cheaper than others. I will touch on that when I talk about the different hormones, but ask your doctor. You can check out goodrx.com for coupons. And then when it comes to the labs, ask your physician for a paper lab slip and call the labs and find out how much the labs cost. You can also minimize how many different labs that you do depending on your medical conditions. And back when I volunteered with Planned Parenthood, we had low-cost labs as well. So there may be labs available in places like that. Where can you get started locally if you don't have access to a provider right now? It really depends on your insurance. And this is not a comprehensive list. This is just people I know. So if you have Medicare, Medi-Cal, including CCH, no insurance, or you're on Esperanza care through Natividad, Laurel Family Practice, hi guys, all the physicians there. At Clinica Salud, Dr. Rebecca Raymond. Down in King City, there's Dr. Laura Bertani, who practices only in that clinic, but also works in our labor and delivery at Natividad. And then at both King City Clinic and Greenfield, Dr. Leah Dalfred and Dr. Joshua Deutsch. I've spoken with all of these people. They all are family doctors who have been associated with Natividad at one point or another, who all say they will provide hormone care. If you have commercial insurance, Prime Care, Dr. Anastasia Click, Athena Medical Group, Chiara Castelli, who's a PA. I can't believe I forgot Natividad Medical Group on here. So Dr. Arias at Natividad Medical Group will do hormones. And then Montage, I just learned of an endocrinologist who says he'll provide hormones, Dr. Kiernan Welsh. And then if you want an OBGYN, regardless of what your insurance is, we have 3 at Natividad who have told me that they'll provide care for trans patients and have in the past. Dr. Soraya Esteva, Dr. Julia Burke, and Dr. Heather Weldon. I know that some of them have had more specific experience with specific things. So I know one of them has helped trans masculine persons through pregnancy, for example. But they all said that they would provide care. There are likely many others within Monterey County who I just don't know of. So consider asking your primary care doctor whether or not they'll provide the care for you. If you need someone else, I can't shout out sctrans.org enough. Go there, go find the list. You can come on up to Santa Cruz County easily enough, and there's oodles of people up here. Or, for example, if you need a comprehensive gender clinic for someone who's under 18, then there's a list of those as well as a list of surgeons and other resources. So at this point, I am going to turn it over to my friend Angel, who's going to share their personal experience of what it's like to be on hormones, since I can't tell you that because I've never have been. Oh, Angel, you're muted.
Oh, I'm muted. Okay. Hi everyone. Thank you for joining. Um, so I just wanted to give like a little like spiel of what it's been like for me. And I want you all to know that this is definitely my personal experience and doesn't reflect all trans people. Trans people have their own experiences and it's beautiful and it's amazing and infinite and I love that. Um, but when I started, it was actually so Dr. Roosevelt is my the other way. Dr. Roosevelt is my PCP, so my primary care provider, and I appreciate Dr. Rose very much. But when I first started, I was with a different doctor at a different clinic at Natividad, and so I started the process there, and I was really nervous, really excited. Um, I had so many questions, and I didn't even know where to look for the answers, but I just knew I wanted to start. Um, and there was like all these changes that I was looking for, including like my voice changing and my body shape changing. But there were definitely a lot of changes that happened later on. And even within this last year, I started beginning of December 2018. And so it'll be 2 years this December. Um, but there's so many changes that have happened even in the last couple of months that I was like, oh, I didn't even know this could happen, but I love it. Like, it's just kind of like, for me, it's this alignment with myself and my body, which is really hard to describe in words, right? Like we talked about gender dysphoria earlier, and then there's gender euphoria. Gender euphoria, highly recommend. It's amazing. um, it's beautiful, and I am so appreciative that HRT and getting surgery is one of the things that, or the main things that have helped me with my gender dysphoria. Um, Also, I wanted to shout out a great resource that helped me out when I was looking for different um, questions to be answered, and that's the UCSF transgender care website. So I'll share this all online as well. And I specifically was looking at the article that's called Guidelines for Primary Care, Primary and Gender Affirming Care for Transgender and Gender Non-Binary People. Um, I really loved looking through that, reading through that, because it's the same thing that my doctors were looking at as well. So it was helpful to just kind of be able to read through it, go through my own questions there first before I talk to my doctors. Um, and yeah, I highly recommend, if you're thinking of starting hormones sometime in the future, I recommend starting the process with talking to a therapist now. For me, it's been awesome to talk to a therapist before the experience, during the experience, and I'm gonna be talking to a therapist probably for the rest of my life. I highly recommend it to everybody, just to help process, all these changes that are happening. There's a lot going on right now too, as well. So, mental health is very important, and very important for myself, and aligns with my gender expression and everything. Um, so yeah, I'm very open to answering questions about my personal experience. Hopefully, to my understanding, we want to get a panel of trans folks to share their experiences as a part of this series later on. So if you're interested, let us know. Um, and just to share a little bit, when I first started taking HRT, I started on 0.5 milliliters, and I was just just now understanding the units. And then I progressed to 0.75 milliliters. And so it's really awesome how you can just kind of adjust to what feels good to your body and your experience. Um, but yeah, any questions from you, Dr. Roosevelt, for me?
I think not today, but definitely in the future, I look forward to putting a panel of folks together to really share their experiences. I think one of the things that I've heard again and again is those little things with hormones that you didn't expect. I have a list of changes that I try to warn people about and a little timeline I try to give them from the standards of care, but you never know. I mean, I know someone who lost her spatial awareness with estrogen and started getting motion sick, and nobody warned her about that. And So I think in addition to a therapist, having support from the community and people who've been there is super important.
Yeah, I definitely agree with that. When I was first looking into things, I definitely talked to a lot of my friends who were already on HRT for years. And that was really, really helpful. Even though our experiences were probably different because different bodies, it was so helpful to learn from them, you know, how time progressed and how the hormones changed your body, changed even, honestly, even like my mentality. Um, it's really wild, y'all. Really cool.
Yeah, even the ability to smell sometimes,
Mm,
believe it or not.
that's awesome.
Power of estrogen.
Yeah. But that's it for
Awesome.
me for now.
Thank you so much. Appreciate it.
Yeah.
And then, so at this point, we're gonna first thank you. That's the end of the formal section of the presentation. Reminder again that the vigil is happening tomorrow, 5 p.m. And at this point, we're going to open it up to questions. I know that we have at least one, which came in, which I can go ahead and answer. And the question is, how would insulin resistance affect starting hormonal therapy? And the answer from my perspective is it doesn't very much. It is something that medically I would want to try to control, because no matter whether you're going on estrogen or testosterone, having insulin resistance raises your risk for cardiovascular disease, whether you have full-blown diabetes or whether you're in that category of pre-diabetes, or whether you're more polycystic ovarian kind of a picture. No matter like which category you fall into, the more insulin resistant you are, the higher the chance of things like heart attacks and strokes and things like that. And whether you're going on estrogen or testosterone, even testosterone, all estrogen in the body actually comes from testosterone. So yeah, me as a cisgender woman, yeah, all my estrogen comes from testosterone that my ovaries make. And then in the ovaries, it gets turned into estrogen. So when you give testosterone, you can actually get a slightly higher level of estrogen, and estrogen increases your risk for clots. So with estrogen comes higher risk of clots that can travel to the lungs, but also things like heart attacks and strokes. So the combination is slightly higher risk, and I put that in quotes because there's a lot that you can do to manage that. Diet, exercise, weight loss, medications that I can provide, although I will say that there is no medicine that I can offer that does anything near what diet and exercise do. So if I could come up with that, I would be a billionaire, and no doctor ever would have student loan debt because I'd pay it all off and it'd be beautiful. Nobody would have to pay for surgery and because I'd make so much money, but no. So definitely can still get hormone therapy if you have insulin resistance is sort of my answer for that. What other questions do we have? Let's see. Yeah, question from the chat. To basically, would you expand a bit about body odor? I take estrogen and have noticed that odor, and I thought it was in my imagination. Totally not in your imagination. I have heard, particularly from trans women, that with estrogen, for some reason, they can smell better. They get more sensitive to scents, sort of like the way that cisgender women do when they get pregnant. Because their estrogen levels go up high too at that point. And so the other thing that I've heard from a couple of trans women is that they notice that they can suddenly smell testosterone and that they didn't used to be able to, but they describe it as this like bitter, almost like a sharp smell, very specifically on just on people on testosterone. And so that's definitely a thing. Body odor, your own body odor can also shift on hormone therapy, no matter what flavor of hormone therapy you're taking. So I know someone who transitioned and she was super worried that her cats would stop liking her because like definitely becomes less noticeable when you feminize and more noticeable when you masculinize. Let's see, other questions. How long does someone have to be on hormone therapy? Ooh, complicated question. Some changes from hormone therapy are permanent. Things like breast growth, clitoral enlargement, hair growth. So with testosterone, the facial hair is permanent. Sometimes with testosterone, you can get a little bit of masculinization of the jaw and the facial features, and that would be permanent. Any changes to bone are permanent. Male pattern baldness, so to speak, is permanent. Those changes you'll have even if you go off your hormone therapy. There are other changes that are reversible. So things like your fat pattern will redistribute. And I'll go more into these details in the future lectures of exactly what changes we know are very common. So those will reverse the moment that you stop. It is medically recommended that you be on some kind of sex hormone for your life. Whether you choose to remain on hormone therapy for your whole life is your choice. You do not have to remain on it your whole life. You can go off it at any point. And I've known trans men go off testosterone so that they can become pregnant and father a child. And so that's totally doable. But if you have your gonads removed, so if you have your ovaries removed or your testes removed, it is recommended that you take a hormone for basically the rest of your life at different doses. Probably we'll just think about discontinuing when you get to like 70. But that because of bone health, because what keeps your bones healthy is effectively estrogen. And remember, testosterone turns into estrogen. So some kind of sex hormone for your bone health lifelong. As I mentioned, and the other question here is, what if I want to stop hormone therapy? You totally can. At any point. It is your body, it is your rules. No doctor is going to sit there and shove pills down your throat or force injections on you. Like, that's not how we roll. But again, it is recommended to stay on some kind of sex hormone at some kind of dose for your bone health. It can be very low dose if you're feeling more neutroy or agendered or non-binary, but some kind of hormone. There's a question here too of what are the different ways to take hormone therapy. The basic forms of most medication are you swallow something, you put something on your skin, or you inject something, or you breathe something in. Don't have anything you can breathe in for hormone therapy yet, although that would be really cool. For feminizing hormones, it's typically it can be any of those three. Because we have estrogen and anti-androgens, which you can swallow safely. For masculinizing therapy, it pretty much has to be going through the skin, transdermal that's called, or injection. And because we used to try testosterone that you could swallow and it killed people's livers, so we don't do that anymore. We don't like livers dying. It just depends. And then if you're doing a puberty blocker, they're called a GnRH agonist to help suppress either usually testosterone, but testosterone or estrogen production of your own body. That is either an injection or that can also be an implant that goes in the arm, just like the Nexplanon does for birth control. Actually, like the same location and about the same size. And lasts for about a year. So in terms of like the actual giving you hormones, swallowing, if you're feminizing, things that go through the skin, so patches, creams, oils, or injection. And then if you are trying to get rid of sex hormones that your body makes, then it's injections or it's an implant. Another question, what if my doctor gets weird about me being non-binary? So about not being binary, and the question is, wanting to transition physically, but not being strictly binary. First of all, I'm sorry. Unfortunately, a lot of medical education the education that I received initially included was very binary focused. It was very focused on that narrative of like, well, there's a journey that you do, and then you end up at the destination, and you have done all of the things, and congratulations. And more and more and more, we're realizing that that is not the case. So a couple of things I think you can probably do. One is if you feel comfortable, talk to the doctor about like, no, I really don't, this is how I identify, and this is the treatment that I'm interested in. This is how I identify, and this is what's going to reduce my dysphoria. And if you're really just not getting anywhere, or you're not comfortable, it's okay to switch doctors. Granted, yes, I acknowledge it can be really hard to find someone who's willing to prescribe hormones. And I apologize for that. We are trying to fix the medical system so that there's more hormone providers. We're trying. The other thing that you can do is probably recommend that they do some reading. So you can refer them, Angel mentioned the UCSF guidelines, 200% recommend. They also have what's called a warm line for medical providers to call to get more training or to get their questions answered. So UCSF is a great hub locally for lots of training, and they will 200% be able to train people on providing good care for non-binary individuals, because a number of the people involved in making the guidelines are non-binary themselves. So we're working on it. So you could refer them to UCSF's primary care guidelines and their support group as well. Other questions. So are the guidelines towards transitioning the same nationwide in other countries? Yes. So the standards of care are a international set of guidelines. The WPATH is an international organization. I actually just attended the conference. We had people from Europe, we had people from Africa, we had people from East Asia, we had people everywhere. US too, we had someone from Mexico. And so all countries are supposed to follow that. Each country does it a little bit differently. The US kind of does this hands off while everybody does their own thing. But if you go to some European countries, particularly the Nordic countries, they have very specific protocols that you have to go through in order to transition. Unfortunately, they still sometimes include things like you have to be sterilized, you have to divorce someone before you can transition, which they are working on it. You better believe WPATH is working on trying to help change that. So different countries do it differently, but it is national guidelines. And so in the United States, universally should be applied. And then another question, are there new therapies for voice feminization that is recommended? Is voice feminization recommended? So from my perspective, the number one place to start is with a voice therapist, because most gender cues, so estrogen and anti-androgens will not change the vocal cords. Once they have changed permanently. But a couple of things you can do. One is most of what tells someone if you're feminine or masculine is not so much in the tone of your voice, in like where in your register you speak, and then it's actually in how you speak. So I use a very feminine vocal mannerism because frankly, I get bored if I do the masculine one, but I absolutely can. And I can, so women in the United States use 7 different notes typically, and we end our sentences on question marks, which makes it sound like we're a little bit unsure, but you can turn that off. And so men in our culture have 3 vocal tones, and they tend to end their sentences going down. And so even without me dropping my voice very much, suddenly I sound much more masculine. I gesture too much for a typical man in this society. And obviously my clothing is not correct, but you can do quite a lot with the way that you speak and the way that you act and the way that you dress to help pass. So a voice therapist can help you with that kind of stuff. There are also oodles of videos on YouTube to help you with that. And if you have a more masculine voice, if your vocal cords have thickened, if your voice is dropped, you can also speak higher up in your register, and over time your vocal cords get used to it, and it's not so much a strain. There is a surgery to shave the vocal cords. I have not kept up with the literature of how effective that was. I want to say before I hit med school, so like 10 years ago, we didn't recommend it very much because it was a little bit touch and go what exactly results you were going to get. And there's always the risk of shaving too much and ending up sounding like a nurse or something else and super high in the register, not sounding quite right. So I tended not to recommend it then, but I have not kept up with the literature and I haven't kept up with how good it is now. But there is a surgery to shave the vocal cords that does exist. And it looks like we are running a little bit out of time. So we've got about 5 minutes left. I, at this point, want to shift over to recommend that all of you follow us on social media. And I'm going to turn us over to our social media guru, who also has a video to share with all of you that we worked to put together. And Haley, you're also muted.
Thank you for telling me. Well, thank you, Rose. Hi, everyone. I'm Haley Gomez. I'm the media content creator for the Epicenter. And yes, please follow us on all of our social media. We're on Instagram, and we also have YouTube. So please go check those out. On our YouTube, we have our last live stream that we did from last month. So if you want to go check that out, you can. But yeah, so this is a mini PSA from Dr. Rose on PrEP, and I hope you guys enjoy.
Hey everybody, it's Dr. Lovell back again with another Q&A video. So PrEP, or pre-exposure prophylaxis, is an incredibly important tool in our toolkit for fighting the HIV epidemic. So let's talk about that. PrEP is a medication taken every day which reduces your chances of becoming infected with HIV if you get exposed to the virus. It's a combination of 2 antiretroviral medications. Those are the same medications we use to treat people who are infected with HIV. 2 brand names that you've probably heard are Truvada and Descovy. Descovy's the new kid on the block. They're really the same thing though. They're a combination of the same generic medications, tenofovir and emtricitabine. Do not try to say that 3 times fast. PrEP is incredibly effective. In clinical trials, the only patients who became infected with HIV were ones who they did tests on the blood of those patients, and they found that they didn't have the medication in their system. So if you don't take it, it doesn't work. If you take it, it works. No patient became infected with HIV in those trials who was taking the PrEP as directed.
Hey, I hope you guys enjoyed. We're going to have more of those little mini PSAs on YouTube and maybe Instagram also. So please keep out a look.
And please do feel free to send us questions. We've got a myriad of ways you can send us questions anonymously and not anonymously. And we will do our very best to answer those questions as we keep going. And that'll be it for tonight, folks. I hope you enjoyed. I hope you found this useful. Please feel free to send us not just questions, but also feedback, ways that we can do this even better. Let us know, because the point of this is to be helpful for our own community, really to help you advocate for yourself. I recognize that the medical environment is not always a friendly one. And we often don't get the education that we need to take care of ourselves. So part of what I'm trying to do is really help provide that information and everything that I learned in medical school and in my medical training, so that we can all be healthier and take good care of ourselves and each other. So in the spirit of that, I hope that you're able to think about going to the vigil tomorrow, and then make sure you have a safe Thanksgiving, wear a mask, please don't gather, take good care of each other, and get the flu shot if you haven't already. Thanks, everybody, and we'll see you next month.